Thank you, Celia. Now we'll hear from Matt Cahillane, who's from New Hampshire State Health Department. Matt?
Thank you, Paul. It was excellent pronunciation of my Irish last name, actually. This is an Irish month, right? We're Irish Culture Month in March, leading up to an unfortunate new kind of cultural thing, which is St. Patrick's Day, which is basically binge drinking and other things. But the real Irish just celebrate poetry and learning. I think it's one of the highest countries, the highest literacy in the world. So my last name, Cahillane or Cahillane, as they say in Ireland, means the defender in the line. So I think that's probably a great description of what I try to do in my work, environmental health. And I just have to say, wow, I'm kind of amazed to be here in the National Academy of Sciences. And when I came in with Celia this morning, I told her, I said, I feel nervous just walking in the door. It's like an old dread from school where you get in the door and you're going to have a pop quiz. I mean, a lot of people in this room are probably the ones that were saying, pick me, but I was always kind of like slipping down when the answer was supposed to come up. And I've done better in life as I've gone through, but you know, this feels like the place where you're supposed to know a lot more. So let's start off, talk about some simple messaging. All right, here's the advancement. So what's the simplest message I can do to start a conversation in New Hampshire or in the Northeast? All right, so basically, it's getting warmer, it's getting wetter, with more extreme weather, right? If we say that, I think we've done a good job. There's really no mention of climate change, no need to argue. I don't need a lot of images and graphics to put that forward. It really starts out things going well in a lot of the conversations we have, and it's very memorable. The last thing I should put in there, which doesn't have a lot of implications for human health, at least in New Hampshire as we studied, is sea level rise and storm surge, but it's a great place to begin. So let's talk about New Hampshire right now and some of the kind of right now funded projects that are going on. I've been working within State of New Hampshire Department of Health and Human Services and under a CDC grant called BRACE, which we'll get into a little bit more. And I've funded a lot of great projects in the last 3 years or so. Right now, currently, we've got 4 that are going on that are kind of local public health projects. I'm trying to press the, oh, here it is, here. So basically, for the last 2 years, we've been working with the Upper Valley. This is kind of the Dartmouth area, Dartmouth College area that you might remember. They're working on heat stress in elders. Here in the Lakes region, working on habitat change, ticks and tick-borne disease, mostly Lyme. We're starting to work with the Monadnock area on storms and resilience. And we're beginning to work with the greater Nashua area, kind of a more urban area where we're working on heat stress also. We've got our main program at the state offices in Concord. And we've got a couple of projects to support those, like Plymouth State University, where we're looking at weather and injuries and trying to get an assessment and help these 4 local organizations basically work on trying to get the information they need to project health burdens related to weather and to climate. So 4 local health interventions I've just talked about. Multiple research studies, and the one on the far right is actually one we're doing in the Great Bay now, which is kind of the Portsmouth area, where we're doing testing for Vibrio bacteria in the oysters there, trying to see as the oceans warm there, do we have more chance for foodborne disease, and can we address that by cooling and shading the shellfish so that they don't end up producing that. You may know there's been a couple of outbreaks with Vibrio up and down the eastern seaboard, and we expect those kind of things to continue if the water continues to get warmer and we don't do anything about it. And as I mentioned, 2 state-level studies looking at heat or heat stress and emergency department visits, actually all cause morbidity, but I'll talk more about that later. And then weather and injury, as I mentioned, with Plymouth State. Just trying to get a sense for what can we say about the true impacts there. Here's some extreme weather events, as people have mentioned here already, not an indicator of climate change, we can't say it is, but what these extreme events are in New Hampshire are kind of set points, right? They're very memorable and very emotional. So I can use those as I get in and engage people and talk about things that affected their life in the state. Thinking about this framework for BRACE, Centers for Disease Control have come up with a framework they call Building Resilience Against Climate Effects. And it's really helpful for the state level, and we're trying to figure out now, can we actually bring it down to the local level? So in the first step, this is a basic public health improvement cycle, right? We assess what's going on, we act on it, try to make a difference, and then we evaluate if we actually made any difference along the way. So in the first step, which is challenging, not something we normally do in public health, we have to forecast the climate impacts and assess the vulnerabilities. So we work with our academic institutions, and we try to downscale data from these large global models into New Hampshire with its own topography and differences, and try and say for the different regions, at least north and south, how are things going to change? How many more days over 95? How many more precipitation events that are 1 inch or 2 inches? And that helps us and helps our local communities better understand the changes that they'll have to prepare for. Second phase is projecting the disease burden. Very challenging. We don't actually do a lot of that. We do a lot of great retrospective work at state health departments. We don't actually project out into the future how that's going to change over time. We do a little bit of work with aging and demographics, but now we're trying to say with things like extending pollen season and a longer growing season, how is that going to affect asthma? How is that going to affect allergies? And can we actually quantify that? The third part, I just identify that because it's probably the most challenging part of what we have to do as a state health department. In the third part, we have to assess public health intervention. So what is the evidence-based public health practices out there that we know can affect current issues and maybe the things that are coming along? So do we have good intervention for asthma? Yeah, it's right in the CDC guide to prevention, community prevention. But for things like slips and falls that could come with changes in weather, for heat stress, things of that sort, not as much information. So we're working on building that evidence base also with the projects we do. The fourth part is develop and implementing a climate change adaptation plan. So basically, putting together a plan that looks like it's going to work well, that reflects the community's needs and our resources, and that's feasible for that same population. Oh, let me go back one. And then finally evaluating, did what we do actually work, and can we reproduce that at the local level? Are we building our evidence base, and can we improve the next phase of it by understanding what's happened? Okay, so going through the steps here, this is the first one, forecasting impacts and vulnerabilities. As I say, we work with local universities and others to try and help us understand what this is so they can do that kind of downscaling and more complex work that we can't do. We use a lot of the CDC guidance for how to do this and how to assess vulnerabilities, and we use existing tools. We have a social vulnerability index that we've talked about, and we have websites for regional hazard data. Under identifying vulnerable populations, this looks a lot like, I think, the chart or the map that Paul put up, and it's based on the same thing. It's based on census data, which is great, right? Because you can get down to the census block level, and it's rare we do that in public health. But this one specifically looks at 14 or 15 indicators, such as education, income, disability, age, if you're living alone, those kind of things, so that in a disaster scenario, whether it's natural or man-made and it hits your community, we get a sense for the vulnerable people who may not be able to adapt well to those changes. So that helps us plan at the state level and a bit at the local level. The second part of the brace, which is projecting health burdens, is much more challenging. We assess health trends using existing tools we have. One of those is a portal that we've built, a dynamic web portal, so people can plug in the health outcomes or behavioral issues that they want to look at, and then look at their local communities, or I should say at least look at the county and the cities in it. And the data looks a bit like this. You're not supposed to look at the details of it, but what's helpful is that you can kind of tell right away, this is for slips and falls. People experience it. Certain areas, like the greater Monadnock area, is certainly higher than New Hampshire, not significantly, but areas like greater Nashua are lower than the average, so we may not want them to focus on those key priorities, we should or shouldn't. And it gives a sense for kind of building that base of information we need for the local communities. Choosing health priorities, I'll get into these later, so I don't have to cover this significantly, but things that rose to the top were heat stress, habitat change in ticks, and extreme weather and injury and resilience. And we have a couple developmental ones where we're trying to look at rising water temperatures and bacteria, which I mentioned, and then changing precipitation, watersheds, and health outcomes, trying to decide as it gets wetter or as it gets drier, depending on the season, how that might impact health. The third part we're trying to do, and we're trying to work with the locals specifically on this, is assessing interventions. So based on the priority health issues we just talked about, we want to try and define the exposure pathway, right? We'd like to know as you look at something like Lyme disease, where are the places you could intervene at the individual level, right, to break that exposure? And that could be helping them avoid tick habitat. It could be helping them, people apply repellent so the ticks don't get on them. It could be helping them learn how to do tick checks so that as the ticks get on them, they can find them and move forward. But we're always looking for a place where we can break that cycle. As part of this, we need to review the existing evidence, which I've already talked about, but it means literature reviews and digging into it. This is one of the challenges at the local level because they don't usually have epidemiologists who can help them with that, but we're trying to do what we can and build the evidence base. So we've done a New England heat study, which was listed in the map of the state, but that's where we're trying to basically get information or cooperate with our local, our regional states. So we're cooperating with Maine, Rhode Island, and New Hampshire to kind of pull more data together so we can say something about as it gets warmer over time, and this is actually a retrospective study. So in the past, on the warmest days, how are people affected? We're very used to thinking of heat stress as how many people actually showed up in the ED because they had actual dehydration or heat stress and an elevated body temperature, but that's not all the impact. There's a whole level of moderate impact that occurs before that where people who have respiratory disease, cardiovascular disease, kidney disease begin to show up in the ERs in greater numbers, and that's actually larger than the actual number that show up for heat-related injuries. So we're trying to tune into that and let local communities know. And use of existing tools like I mentioned, the CDC Community Guide, and then we have a communities of practice at the national level that are helping us dig into the literature and understand it better. So we developed a state strategic plan for this. So at the state level, we're basically looking at how do we build workforce capacity, how do we improve education and outreach, and then thirdly, how do we improve policies? So not just legislation, but how do we get in and address policies at the local level, which might be something as simple as in a daycare center, do you have an opt-in or an opt-out policy for using repellents, right? Right now, they have an opt-in policy, which means if you want repellents applied to your child, you have to sign a paper saying that you want that to happen. Well, that makes it much more difficult. If we believe the repellents are less risky than Lyme disease, it really should be having an opt-out policy, right? Where if you don't want them to get repellents, you sign off. So little things like that can make a big difference. Now there's a big burden on it because people are so concerned about chemicals, but it's not as dangerous as the infectious disease that might result without it. Here's the 4 locations where we have, which I mentioned already, so I won't go again. I'm going to basically review 2 of these quickly so we can understand them. So here's Upper Valley. This is the kind of Dartmouth area one where they decided that they were going to engage with their local advisors, assess the wants, needs, and hazards. But another key part of this that I don't have in here is they hired their regional planning commission to basically work with them to do the assessment process because it's complicated, and that brought one more player in and an opportunity for collaboration. They prioritized areas of rising temperatures, heat stress, and injury, and they focused on targeting older adults and shut-ins, right? There are some groups that work on heat injury, and they focus all elders. They focus on elders in nursing homes. Well, nursing homes aren't the problem that we have. We want to focus on those people that are out in the community. And they intervene via an educational lecture to caregivers and older adults to learn the risk factors, and they evaluated the results with a pre-post test for caregivers. Not a lot of change there, not significant, but it's the beginning of it. New Hampshire Lakes Region Tick Project, very similar approach to engaging with their local advisory county council, public health council, which is made up of representatives of the community. They prioritize habitat change, tick exposure, and tick-borne disease or Lyme disease. And they targeted outdoor youth in recreation programs, which is great, right? Those are the kids that are going to be at most risk for being exposed to ticks. They intervene with an education of adult recreation staff and students, which is probably a little too much to do at once, in order to reduce it, and they evaluated the results with a pre-post test for risky behaviors. Okay, evaluation of impact. What did we learn from this, working with these 2 local groups that are further ahead? Limited ability really at the early stages to show quantitative change in knowledge and behaviors. That's tough with kids anyway, but via the pre-post testing. But some success in qualitative change in the amount of community collaboration with like the local planning commission and their local recreation departments and elder care services. And finally, maybe a stronger case for making changes to policy and rules for engagement with decision makers and vulnerable populations. We haven't talked about it, time to talk about it here, but we were able to engage with the National Weather Service and work on a project where they're going to be lowering the threshold for when they put out their warnings for it, so more of those moderate health impacts can hopefully be addressed. So, lessons learned. First one is definitely a standard planning process like CDC Brace is great. It's worth more than the final written plan, which often ends up on a shelf, and it supports greater collaboration. Engaging with opponents of climate science is rarely successful for the community good. I've talked with some other people about that here. There are a lot of people who want to engage, I think, in the climate debate because they want to make people uncomfortable and decrease our civil discourse, right? If you can get everybody in the room feeling uncomfortable, you can suppress that conversation. I think it was George Bernard Shaw said, I learned later in life not to wrestle with a pig. You both get dirty, right, and the pig enjoys it. Not calling these people, not calling them pigs, but some people really enjoy the argument and want to engage in that just so everybody feels dirty afterwards, right? And they don't want to engage with climate issues or other uncomfortable issues. And finally, a seed grant project led by the local health agency will take a lot of time, patience, and support. I'm sure it took more than 50% of my time over the last 2 years to get these 4 projects going. And just to give a perspective, probably invested $20,000 per year over 2 years, plus other support. I'd say to get each of these going, it was probably anywhere from $60,000 to $65,000. So I think that's really what it takes to get it off the ground and get going with it. So that's it for my presentation on that. Happy to have any questions afterwards.
Thanks, Matt.
All right.
Thank you, Matt.